Hello, it's Anthony Chadwick from the Webinar Vet, welcoming you to another episode of VETchat, the UK's #1 veterinary podcast. Really pleased to have Nicola Read on today, who is a veterinary nurse based at the RVC, specialising in oncology. Nicola did a PGC in oncology, and then a master's in oncology, both at Harper Adams. She's been at the RVC since 2002, and really looking forward to chatting to you. But perhaps for those people who don't know you, Nicola, you could give a little bit of an introduction about yourself.
Hello, thank you for inviting me, Anthony. So I am a traditionally qualified nurse. I did the old-fashioned apprenticeship route, so qualified in 2000 in a North London practice, which was great fun. It was a family-led business, so it's a very nice setting in order to be able to learn the disciplines of all the different skills required of nursing. And then wanted to do more and specialise in particular in medicine nursing, so moved to the Royal Veterinary College in 2002, where I was a medicine nurse. So then did my diploma in advanced veterinary nursing, which was organised with the BVNA at the time, which was fantastic. And then went on to be the head medicine nurse in, I think, around 2007, I want to say, something along those lines. And then medicine just grew and grew and grew, and we ended up with a specialist oncologist at the RVC. And I got the very privileged decision whether or not I stayed with medicine or went and worked more specifically with the oncologist. And so together we set up an oncology service here at the RVC. And that's where I've remained, looking after patients with oncological disease, working with a team of specialist vets and nurses. So I feel very privileged to be in the job that I do, because it's one that I absolutely adore.
Yeah, and I would imagine 2000, I remember those green books and having to sign,
Yep.
multiple times that you'd done things and things.
Yep.
So it wasn't a bad system. And then I remember doing D32, D33, which
Yep.
was
That's what I did too.
hard work.
Yep.
But it's great to see the way that veterinary nursing has developed, with specialist diplomas,
Yep.
with masters, PGCs, etc.
Yeah, it's amazing.
It must be a lot different than when you first started in, at the turn of the century.
Gosh, you make me seem really old. It was actually, and I think I don't believe at the time there was any sort of like academic route. It was
Yeah.
very sort of like based on trade and profession. Obviously, we now know that veterinary nurses have a protected title as registered veterinary nurses. So all of this, the whole profession has evolved. We're recognised like alongside our veterinary colleagues as well, and it's just a fantastic place to be in. I was really lucky to have been given the opportunities that I were in order to get onto the postgraduate certificate, because I wasn't a degree nurse, and normally that's the
Yeah.
pathway to have. So I had to do some bridging, and I had to do a lot of learning about how to critique things and understand how to write things very differently to how I have been educated before. But it's something I absolutely like, really do enjoy, and research is a big thing with regards to sort of the opportunities that we have as veterinary nurses, and especially in the institution where I work as well.
Yeah, we love veterinary nurses at the Webinar Vet. I think vets and nurses working together is so critical, isn't it? And I think
Yeah.
also with the Webinar Vet training, a lot of training can be quite basic, whereas learning, some of the GP stuff, anesthesia, obviously radiography, etc., behavior, nutrition, nurses can really go to another level, and that really supports the vets. We do, I'm hopeful. Obviously, I've not been in practice, but nurses cleaning kennels out all day is not best use of their time and resources when you are as qualified as you and many of your colleagues are as well.
Yeah, I mean, I still clean kennels, definitely. It's part of my daily job.
Yeah.
And I think the thing is that it's a collaborative approach, isn't it? I'm lucky enough that we will have patient care assistants that work here. We have undergraduate veterinary nurses and veterinary students as well.
Yeah.
And we all like literally collaboratively get the job done. Obviously, there's very distinctive roles that we all have, in which is part
Yeah.
of our responsibilities and our professional obligations. But I absolutely agree with you. being able to use nurses now for their specialist techniques and their abilities is certainly something which is progressing, and very encouraging to hear as well.
So, talk to me a little bit about your role as an oncology nurse and how do you work with the oncologist at the RVC?
Okay, where do I start? So, what about my average day? Shall I do
Yeah,
something
that
like that?
sounds great.
Yeah,
An
my
average day would
average
be
day.
great.
So I
If there
have
is such a thing.
Wow, very, very good point, but I will try to make it as consistent as possible.
Yeah.
So we have two different days at the moment in which we run. So we have days where we have new cases and patients coming in for restaging. So that's quite exciting. We have a lesser number of cases on those days because these clients come in and they need a lot of time spending with them with regards to their educating them and helping them understand all the different processes that can be involved with regards to forming a diagnosis and making sure that we can determine their extent of disease. So we have a CT scanner here, we've got digital radiography, we can do scintigraphy here, and we've got an MRI scanner as well. And then we've also got fantastic radiologists and radiographers who help us with regards to very specific sampling when
Mm,
needed. So those patients take a lot of time as they're worked up. We instrument them. By that I mean we put catheters in to them, get them ready for their sedations, things like that, and then we follow them down to imaging, help them with regards to their sampling as well. So we might be there sort of smearing slides or going down to the lab and just checking to make sure that they're of good diagnostic quality, because the last thing you want to have happen is that the animal's woken up and the sample's not a good enough one. So we
mm,
want to make sure that what we send off to our pathologist is perfect and at least good enough to make a diagnosis. And then obviously we recover these patients and send them home to be awaiting their results. So that's kind of one kind of day that we'll have, and we'll also have the patients that come in for restaging, which means measuring their disease against their
mm,
last lot of imaging to see whether or not the treatments we're giving them is having a positive effect. So, and then normally reported as being in complete remission or partial remission. Sometimes they have stable disease, so we give them treatments and their cancer's not progressing, which also isn't a bad thing.
mm,
So as long as they've got good quality of life, then that's fantastic. Or sadly, sometimes we see these cases come in and despite the treatment interventions, they've got progressive
mm,
disease. So it's about sort of coaching the client through those stages as to what happens next. And we're there as nurses to help support the clinicians and the vets and the residents and our rotating interns to help do that.
mm.
So, yeah, that's one kind of day. And then the other day is we have our chemotherapy days. So, for 2 solid days of the week, we have a number of patients that come in for different types of chemotherapy. That might be oral treatments or infusions or bolus treatments. And we have a real emphasis on the patient's experience. So, making sure that they come in, it's as calm, as quiet, as individualized for them as well. So, we make sure we try to work out very early on in these treatment protocols what they prefer. Some of these patients, or quite a large number of them, are geriatric, so they've got comorbidities. So we need to make sure they get comfortable if they've got to sit for, say, a 20-minute infusion. We use a lot of EMLA and topical local anaesthetic aids so that
Yeah,
they're having as least invasive experience and all these
yeah.
negative things that we associate with these treatments being done. So we'll have sort of 10, 12 of these patients coming in and being treated throughout the day. So, and then they all get lots of love, lots of attention. They all get fed and exercised and cuddled and things like that as
Mm,
well. And then we discharge them back to their owners with instructions on how to look after them post treatment. So whether it's the right at the beginning of the treatment, and we need to spend a lot of time educating the client at all the different signs they could be looking out for, or whether or not it's routine and it's a case of just touching base with the owners and listening
yeah.
about all the nice bucket list things they've done that week, which is fantastic
Oh,
to hear.
great.
Yeah, yeah.
And do you leave catheters in if they're in weekly, or do you need to remove them and just redo them each week?
Yeah, it's a really good question. It's very different in animal medicine than it is in human medicine, in the sense when a human is undergoing a treatment protocol for chemotherapy, they have these, like they call them PICC lines,
Yeah.
so peripherally placed intravenous catheters. Um, Sadly, we can't leave them in our
Yeah.
animal patients because of the risk of them pulling them out,
Yeah.
risk of them getting infected, or there's sort of patient interference. But there are a small cohort of patients which we place ports in, so vascular access ports, which are
Yeah.
really super cool. If we're able to be proactive with regards to what kind of like cancer we're dealing with, so osteosarcomas, so tumors of the bone, or hemangiosarcomas, which are sort of like nasty vascular tumors, we can put a port in at the time of their surgery to either do their limb amputation or a splenectomy, for example. And that port sits within the jugular vein, but it's implanted either on the back of the neck or in the femoral vein, and it's then on their hip, and it's just almost like a subcut injection in order just
Right.
one literally, and it enters the port underneath the skin, which is amazing. So again, focusing all the time on the patient experience.
And the innovation is great, isn't it? To see things, how can we all the time make this better?
Yeah,
What things can we do to improve health? And I know, I'm not sure if you're known by your friends as this, but you are to me the nausea nurse, because obviously that's what you did your masters in. So
yeah.
tell me, I mean, how common is nausea in the patients that you're treating, or are you treating preventatively to, prevent nausea in the first place? So how
Mm.
has that developed over time?
I think it's a really, really interesting thing, and nausea for me is a very so there's no way of quantifying nausea. There's no
Yeah,
nausea scale, and it's something I
yeah,
really, really want to collaborate with people on and be able to do something like that, like what we have similar to pain scales. I think nausea is completely and utterly underestimated in these patients. Nausea for me will be very different to nausea for you in
mm,
regards to how you describe it or how it sort of manifests itself. And I
yeah,
think that must happen in the same way that it does in animals. And because we assume, so we're looking for vomiting, aren't we? Signs of like gagging,
yes,
hypersalivation, things like that. But the actual end product is the vomit, which then makes us give them antiemetic medications.
yeah,
And so I think a big thing is to be able to educate our owners so that they understand the different sort of like presentations of what nausea might look like for their animals and be able to nip that in the bud much earlier. Um,
yeah.
so yeah, I think it's an area which we can definitely develop on and do better with, all of us really.
So would you say there's particular treatments that are much more likely to cause nausea, and so
Yeah,
therefore do you use, pharmaceutical products preventatively,
yeah.
or do you always wait until there's a problem before you begin treatment?
So there are some chemotherapy drugs in particular which are known to be very emetic.
Yeah,
So drugs like doxorubicin, carboplatin, for example, are reportedly known to be through studies and through um, various reports in the
yeah,
cases that these patients really do need to have these treatments. So we'll often give them antiemetics prior to giving them their chemotherapy, and then we like almost give them like little first aid boxes, so to speak, so that they go home with treatment to be given at home for a number of days, usually about 3 days for specific treatments, for them to sort of like get over that period of the initial feeling sick,
mm,
so to speak. Because we want these patients to be having good days, like as the majority
yes,
of the week, than bad days, because sometimes they're coming back on a weekly basis. So if they're feeling sick and off their food for sort of 2 3 days, which is quite common, that's the sort of acute chemotherapy post treatment
yeah,
phase, that they could feel unwell for, that's quite a majority of a week, isn't it?
yes,
So yeah, we do give them preemptive treatments, sort of like almost pre-medications of
yeah.
antiemetics, and then they go home with post-treatment antiemetics as well.
And what sort of products are they going home with or being used here? You can
So
obviously,
the right answer is always to be that we have to use products which form part of the cascade.
yeah,
So, anti-nausea medications is the first go-to is always going to be meropitant.
yeah,
So, and the reason being is meropitant is produced as a multimodal antiemetic drug because it affects the different types of triggers within the brain and the
yeah,
gut as well, with regards to treating and inhibiting that effect. There is a condition known as breakthrough nausea, or breakthrough emesis. So essentially, you give them their antiemetic medication, and then they break through that, and they're still feeling sick. And then usually the next go-to medication is ondansetron. And interestingly, ondansetron is the drug which works on the chemoreceptors within the brain, which is your main sort of like brain trigger for causing sickness,
Yeah,
and ironically is called your chemoreceptors, which is kind of cool. But essentially,
yeah.
it detects any kind of sort of toxin within the body, and that's what then initiates this nausea pathway. So if they do still feel unwell, or they're not eating, or we feel that they've got signs of nausea, then we'll add in ondansetron as well, usually. But
Hmm.
there's other products which can be trialed as well, like metoclopramide, for example.
Yeah, my old favourite before all these other drugs came along,
Yeah.
meropitant. So I think, yeah, metoclopramide was very popular
Yes,
at the time. So, but
certainly.
being superseded by meropitant, which I think is works very well, doesn't it? Most of the time.
It does, and a lot of work and obviously a lot of money and research went into developing meropitant as well.
Mm.
And specifically, meropitant was used and tested in in a research setting, specifically on chemotherapy
Of
drugs.
course. Yeah,
So you know that it sort of like substantiates that evidence with regards to that that's what we need to be using first line. But there are a number of patients where it doesn't always work on, and that's what we it just because we gave them the antiemetic doesn't mean to say that they're still not having that
yeah.
experience, and that's what's really important that we do monitor them for as well.
Cancer and oncology is it's such an emotive subject, both for humans and for animals. Obviously, with animals, it's the client that is most likely to get upset. There is a feeling that we're now on this cancer journey.
Yeah.
Obviously, sometimes with full cure and remission, but other times, there is a slow decline.
Hmm.
How do you cope with that? One as a nurse, that presumably there are successes, but there are also times when you have to make the big decisions at the end. How do you cope with that individually, but also portray that then out to the clients that you're dealing with? I suppose I'm asking, are you a hopeful person? Can you encourage and cheer up people when they have a diagnosis like this? That presumably the diagnosis is kind of being considered because that's
Hmm.
why they're being referred across. But then
Yeah.
you're often the ones who can give the definitive news, aren't you?
Yeah, I mean, as you say, we're on this cancer journey with them, and I suppose it's almost a double-edged sword. Professionally, I'm always very optimistic and very hopeful, and I'm there to do the very best for that patient. Personally, glass is always half full, and I'm always
Yeah,
catastrophizing, but I can't let the clients
yeah,
know that
yeah,
at all. But I do feel it's a huge honour actually to work with these animals and these clients. Um, Cancer treatment actually, the majority of the time works really, really well. We don't use the same kind of doses that we do with people. So the animals don't have anywhere near the side effects that people do because we're not aiming to cure most of the
yeah,
time. Cancer treatment in animals is palliative, for want of a better word, but we don't use that word. We just want their clinical signs to go away. So
yeah,
actually, after the first treatment, sometimes like a couple of treatments, these animals are like back to themselves and they're feeling better, reportedly by most of our owners, that they're better than what they've been in the past year because
yeah,
understandably they've had a slow decline with
yeah,
regards to their disease. So it's like I say, it's a huge honor to be able to work with such cases. Clients and these animals have like a new lease of life. They also respect the time that they have together. And I think a lot of investment does need to go in at the beginning to educate the owner with regards to the expectations and the
yeah,
likely progressiveness of the disease. So as long as they're getting these rewarding days, their days at the beach, their sort of their days out, and all the things which these animals and these owners enjoy, it's a really amazing thing to be part of. And whilst that's happening, it's great. The patients come in, like you'll call someone from the waiting room and the dog's running at you, dragging the client behind you because they want to come in and they want to sit down on the scales and get their treat. And they want to sort of like run in. We have some dogs who lift their head up for their jugular blood samples because they know what's going to happen and they're going to get their treat and they're
Yeah,
wagging their tail the whole time.
yeah,
Um, that's a really nice thing to be part of.
yeah,
But then at the end, it's not so enjoyable, as you can imagine. But again, it's a huge honor to be able to see these animals through all the way. And part
yeah.
of their end time that they have is just as important as all those good times, because these are these are the core parts that the owners are going to remember as well. So being able to be there and make the end points of their end of life care as comforting for them and their owners
Yeah,
is really, really important. So the whole when there's no more treatment options for these patients and we have to look at hospice care and things like that, it's about working with the client and making sure that all of those end points in which these animals are getting to are palliated as much as
mm,
possible, and the owners are able to look after them and enjoy them and say their final goodbyes.
yeah,
And that's hard. And
yeah,
as we said, I'm slightly of the older and traditional age, and I have got to points sometimes where I just feel really, really upset.
yeah,
And we're a very close knit team. There's sometimes where there's days where I'm like, can I tag out of this one because I'm just not able to do it.
yeah,
Um, and I'm lucky enough to be able to do that. But there are times where you just have to put on your big girl pants and go in there and do it and make sure that it's the
yeah,
best thing for everybody. And we look after these animals in their aftercare, like post euthanasia, as if they were our own. They're carefully wrapped and prepared, and we put them into cardboard coffins rather than into bags and things like that as well. So yeah, it's a big thing for us as well, the end as much as the duration.
yeah. I think it is. You absolutely said it right. I always felt those euthanasia consults were so important that they were
Mm,
done well.
mm,
A privilege often, certainly in my situation, I knew the clients very well. I knew the pet very well. We'd been on a journey. Might have known these animals since they were puppies. Obviously, a bit different, with the referral situation. But nevertheless, even with the referral situation, you're seeing these dogs regularly. So you
mm.
develop, or cats, you develop a relationship, don't you?
Yeah, absolutely. It's the same as like absolutely as in first opinion. A lot
Yeah,
of veterinarians and veterinary nurses, they're core parts of the community, aren't they? So you see people when you're out and about and you see their animals as well, and you want to do the very best. And despite that, sometimes there's the joys that you have of them being pups and kittens as they turn up into practice, or a new rehomed animal. It's fantastic. But then equally at the end you're there and you're relied upon, and in order to do the
Mm.
very best for that pet and their family.
Yeah. It's difficult. I suppose sometimes there is also the involvement of the referring practice because that may happen at the referring practice, but
Yeah.
quite often it also happens at the RPC, does it? The final stages.
Yeah, it does. I mean, we have a very wide catchment area, so to speak, of almost from because we're just north of Hertfordshire, so north of
Yeah,
the M25. So there are other referral centres for oncology quite close to us as well, but it tends to be quite a wide area that we do look after these
yeah,
patients from. We've had two this week come up from Brighton, for example.
yeah.
And so we don't want them traveling, do we, in
No,
these last sort of
yeah,
like hours or days? And so we do rely very heavily on our first opinion referral practices who obviously refer them into us. And it's about having that good relationship with that
yeah,
team as well in order to inform them and help them with all of our clinical notes as to what point we're at, what all the things that we've tried, and now what the goals are when it comes to hospice care or palliative care in the home, so that the owners feel as well supported as possible. And also try to make a plan together, so the owners and the first opinion practice, or whether or not it's us as well, so that you've got as much of an organize so things are organized as much as possible, whether you're talking like fur clippings, nose prints, all
mm,
those mementos which the owners want to
one,
want and want to remember. Some don't want
yeah,
to do anything at all, but some want a lot. They might be very spiritual, and have prayers or a ceremony, and it's
Yeah.
important that we help coordinate that where
Yeah.
we can. And obviously, with the first opinion vets, they're extremely busy. They don't have an hour for a consult like what we do in
Yeah.
referral practice. I remember when I was working all those years ago, in North London, they were 5-minute appointments,
Yes.
and they would be 10 minutes, 15 tops for a euthanasia in the middle of like the consult list. So I'm sure there's still practices that still have to work that way, and
Yeah.
so it's a hard thing to do for everybody, and I completely appreciate that. So we're here to try and help coordinate and introduce as well. To There are hospice providers as well popping up, where
Yeah.
because there's a lot of vets that aren't able to provide euthanasias or visits anymore because they're also short staffed at this time. So it's
Mm.
just trying to find the right balance with every family.
I think, listening and chatting to you, it's clear you're a really good communicator. And I think communication is key to all of this, because this is when things go wrong, if things aren't communicated well or if things aren't explained well.
Yeah. You have to have a collaborative sort of approach, don't you? You've got to be open and transparent.
Yeah.
Make sure that the clients know everyone's got to have a common goal, haven't they? We can't want
Yeah.
to do one thing and the owner wants to do something else. And it's about trying to do the very best for the animal, because that's what we're here for. That's what our oath is for, isn't it? But obviously, this animal is attached to the owner, and the owner sometimes has enhanced wishes, whatever they might be. And it's about working together in order to meet everybody's expectations for the
Mm.
end goal for that animal to um, be as most comfortable and have the best quality of life possible for whatever finite time they've got.
I always used to say to clients, there's three people in the room. There's me, there's you, and there's the dog or the cat. And
Yeah,
actually, as
you're
long as we
absolutely
remember
right.
that the cat or the dog is the most important, and we make the right decision,
Mm,
and we don't leave it too late. I'd rather do it 2 weeks too early than 2 weeks too late, because we all know the cats that come in that look skeletal when they come in, and the client says,
yeah,
"I didn't bring it in any sooner because I knew you wouldn't be able to." You'd put it to sleep, and you go, "Well, you know, haven't given me a lot of choice." So I think that's really crucial, isn't it? That we're
yeah.
always having the pet at the centre of the discussions.
Mm, absolutely. And I think a key thing to pick up from what you just said there is that that animal didn't come to you 2 weeks before because they were worried that you were going to put it to sleep.
Mm,
But actually, that 2 weeks could have still probably happened with your intervention to make that animal much more comfortable, whilst
exactly.
everybody then was a little bit more
Yeah,
prepared.
yeah,
Because there's all the standard medications which are provided in practice, from antiemetics to steroids
yeah.
to your tradition. All of your pain reliefs can be given at home, and so these kind of things are paramount to also the owner being on board for the end decision. If they're too
Yeah,
scared to come to us to talk about these things because they think that we're just going to put them to sleep, then that animal's going to be suffering in that meantime, isn't aren't they?
exactly.
So
Yeah.
yeah, that working together.
Nicola, I've really enjoyed my time chatting to you. I was at the RVC last week. It's an amazing facility that you have there as well. And not only do you have the facilities, it's obvious from speaking to you that there's a lot of love and care going on as well. So thank you for
Absolutely.
all that you do for the pets.
Bless you. Thank you. Thank you so much for the invitation. I've really enjoyed speaking to you today.
Great to speak to you as well, Nicola. Thanks everyone for listening. This has been Vet Chat. Hope to see you on a podcast or a webinar very soon. Take care.